Hi everybody, we've finally got to the main event, the best part of every module, which is where we start to pull together all the theory and turn it into something that hopefully will make sense within a patient assessment. And what we're looking at here is the follow-up review. Now, I know that this is familiar with you. We had a look at this in the previous lesson, which was a PDF that I kind of got you to read. We will be going through each of these care processes as part of the patient review. But before we do that, I just wanted to mention about this thing. Retinal screening. This is the 9th care process. However, it isn't our responsibility within primary care to kind of be involved with this. It's delivered by the retinal screening service. We do kind of have some responsibility. We need to make sure that our patients are referred on to retinal screening. And also it doesn't do us any harm to just double check when they come for the review that they are up to date with it. Sometimes in different areas, sometimes services can, it might be that in one place retinal screening is fabulous and everybody gets their eyes done every 12 months. In other areas, for whatever reason, sometimes it can lag behind a little bit. So it's not our responsibility to do anything aside of make sure that the referral has been done and our patients are getting their eyes tested. Now then, I think I must be going a little bit odd in my old age because I've started looking at proverbs and things like that. But anyway, there's one proverb that I saw and it really made me think about type 2 diabetes, and it's this one. If we take care of the pennies, the pounds will take care of themselves. You know, what they're saying is if you take care of the little things one at a time, then they add up to big things. I've been writing courses and teaching diabetes for well over 20 years. And when I first started, I used to do every tiny little disease to an obsession. But it took me a good while to work out that actually, in the big grand scheme of it all, there are 3 core aspects of the diabetes review that we have to cover anyway, but actually they form the basis of the assessment and management of all those opathies that you can get when you've got type 2 diabetes. And the 3 little things, and they're not little things, but you know, in the context of this, that we need to take care of is the HbA1c, blood pressure, and finally lipids. And the thing is, if while you're doing a diabetic review you can get all 3 of these under control, you're in with a really good shouting chance of slowing down progression of all of those opathies that patients get with diabetes, and also reducing future risk of things like heart attack and stroke and acute kidney injury and all the awful things that people with diabetes can end up with, really. The thing is, if going through your blood vessels, you've got blood that has got too much cholesterol in it, too much insulin, too much sugar, and it's been fired through under pressure, the chances of this lovely lining being damaged is really, really high. And that's the principle behind this. So if we take care of the pennies, the pounds will take care of themselves. So let me just refresh your memory on this before we get into the assessment. So there's our blood vessel. Let's pretend that we've got too much insulin in there. Because we've got too much insulin, that's because we're insulin resistant, you see. So if the insulin can't stick, it'll stay in your blood. But if it can't stick, it can't get glucose out of your blood and put it into the tissue. So we end up with too much glucose in there. And remember, Insulin is as good at getting lipids out of your blood as it is as getting glucose. It makes sense. If it can't do that, you're going to end up with lots of lipid. And last but not least, I mentioned this thing called oxidative stress, and that just makes a bad job even worse. And when you've got all of this, when you've got blood, and in that blood you've all of these chemicals, it's almost toxic. It's like caustic, and it's bathing your blood vessels. And before you know it, it's taking the lining off them. And the other bit with that is not only is it taking the lining off, it's taking cells that can secrete anti-clotting factors. You know, it's taking cells that create chemicals that relax your blood vessels. This is why in diabetes, you know, we've got all of these vascular problems. And so if we take care of the pennies, if we get rid of the lipid and the glucose and the insulin, your body won't have to fire out all those oxygen-free radicals. And before you know it, we would end up with a better environment within the blood vessels. You can't fix what's gone wrong, but what you can do is you can stop it getting any worse. It's things like retinopathy. If you've got a patient with background retinopathy, whilst you might not be able to fix what's gone wrong, you can certainly stop it progressing into a more severe form of retinopathy that can threaten eyesight. Okay, just to kind of put all of this into perspective for you. When we talk about macro and microvascular complications, that's, you know, what we're looking at there. There's so much evidence to show us that the risk of microvascular small vessel complications, it increases significantly when your HbA1c goes up to greater than 48. And with the macrovascular, this increases significantly when HbA1cs go up greater than 53. One of the big, huge landmark studies that we had in diabetes was called the UK PDS. Now this was massive. It ran for 20 years and it ran across 23 different sites across the UK, and it covered over 5,000 patients with type 2, and it followed them for 20 years. And after that 20 years, what it kind of came up with was this. Complications of type 2. Previously we thought, oh well, of course they're going to have a heart attack, they've got diabetes. We thought it was inevitable. It's not the case. We can reduce that by sorting out the blood pressure and the blood glucose levels. Just have a look at this. For every 11 millimoles that we reduce or we take away from an HbA1c, the chance of them developing small vessel damage drops by 37%. And it's a 21% reduction in the risk of death. So glycemic control is really, really important, but we can't just do glycemic control. We've got to sort that blood pressure out as well, because remember what you've got here, you've got blood vessels that have been being bombarded for many years, you know, with too much sugar and lipid and insulin and oxygen-free radicals. You know, they're kind of, you know, they're a bit fragile, aren't they? So we still need to reduce that blood pressure. The thing about reducing your blood glucose, because of how insulin works, because of how insulin takes glucose away, if it's taking sugar away, it's also, if it's getting better at doing that, it's also getting better at taking lipids away. So that's a kind of little background for you. As we have done with all of the other modules, we're going to do this via a case study scenario. So let me first of all introduce you to our patient. Okay, so this is Jim. Jim's 72 and he was diagnosed with diabetes 2 years ago, and today he's here for his 6-month follow-up review. Now then, Jim has only just recently retired. However, he does keep himself busy doing odd jobs for neighbours and family and friends. He has always been active, and he is a member of the Village Rambling Group, so he does lots of exercise. Aside of his type 2, Jim also has got diagnoses of hypertension and angina. Now, he's been married to Anne for 50 years, and he's now actually her carer because she suffers from rheumatoid arthritis. She's also got type 2 diabetes, and 2 years ago she was in fact diagnosed with kidney cancer. Prior to all of that, she ran the home, you know, traditional family. Jim went off to work, brought the money home. Jan did everything in the house. Sorry, Anne did everything in the house. But she now feels desperately guilty because he's having to do most of the housework and the shopping and all the cooking. But he just gets on with it and he does his best. And he tells you he knows that his standards are not up to Anne's standards. And she's not all day at letting him know that, by the way. But he's doing his best. I mean, the point is with Jim is he has a lot on his plate, you know, and this is often quite the case for a lot of people with chronic disease, you know. I think sometimes we forget that, you know, they come into our surgery and they sit in front of us and they're our patient and we're bothered about Jim because he's got diabetes and hypertension and angina. But when he gets back home, Jim, he's the carer, you know. He's not the patient, he's the one that looks after someone else. And this can have a big impact on outcomes for patients with chronic disease. Right, so let's do our review and let's start where we need to with the HbA1c. Now then, what the guidelines tell us is that all HbA1c targets should be individualised. So what we can't do is we can't have one size that fits all. We used to a few years ago, but that isn't how it is. So lots of things that we need to take into account, and I know that you've seen these before, so that's why I'm going to whiz through them. But how do we do this? So how do we do this in such a way to make sure that if you were setting an HbA1c target and then one of your colleagues did, what tool could we use to make sure that, you know, we're not using our subjective opinion? Well, there's lots of different ways that you can do it. The one that I absolutely love and the one that I'm going to show you is one that has been developed by the American Diabetes Association. So let me take you through it and then we'll apply it to Jim. So here it is. Let me take you through what we're supposed to do. So you get your patient in and you've got to consider all of these points. And then what you have is like a little bit of a clapometer. And what you do is you put a mark on here where each patient sits. And ultimately, you'll end up where the patient, the little line, you'll have more lines under one number. Now, over in the States, they reference an HbA1c as, they don't just have one fixed, right, it's 48 or nothing. They have a little sliding scale, if you like. And their definition of more stringent is an HbA1c of 48. Less stringent is 58, and the middle of the road is 53. So what our job is we need to set a target 48, 53, 58 for all of our different patients. So let's have a look at what we would do with Jim. So there's our lovely Jim. Jim is prescribed, so we'll start up at the top and we need to know what risk has he got of having hypo or any other adverse drug events. Well, he's on metformin and he's on another class of drug called an SGLT2 inhibitor. Okay, so let's get our little clapometer up here and let's spin it along. If he was just on metformin, we'd probably have it here because he's got a very low risk. But as you heard in the previous video of the young girl who was having the hypos, it's never a not risk. The more drugs that a patient has, the greater the risk of hypo. So I'm going to put Jim at about here. If he was on insulin or a sulfonylurea, we'd have him right up here, especially if he was on other drugs as well. Okay, so that's that bit. Next bit, well, Jim has had it for 2 years. However, when we had a route through his records, there's a big suspicion that he's had it quite a bit longer, but it wasn't diagnosed. So let's get our little clapometer marker back up again and let's fire that up there. I think that's about fair enough. Okay, life expectancy, well, is 72. So I think we're going to probably go up there a little bit. Next one, important comorbidities. Well, he's got hypertension and he's got angina as well. So again, we're going to push those comorbid conditions up a little bit. Oh, there's the angina popping up. That's his established vascular complication. He's a carer. So to be honest, he's so busy looking after Anne that sometimes he kind of ignores his own needs. So we're going to fire him up into the middle. And at the bottom, again, he often puts her needs before his. And as a consequence, he does confess that, yeah, he does sometimes forget to take his meds. He's that busy making sure that Anne doesn't miss any of hers that he sometimes forgets his own, you see. So what we would do now is we would look, and I'm going to say that I think that looking on there, I'm going to put Jim at a target HbA1c of 53. So I don't know what you think about that. I'll put this on a little PDF and then you can download it and use it yourself if you want to. But I quite like this. Nice guidance. You know, what they say is if your patient's on a drug that can cause a hypo, set it at 53. If they're not, set it at 48. But to be honest, there's so much more to a person than just whether or not they're on a drug that causes a hypo. So I hope you found that useful. So let's have a look at Jim's HbA1c now. Let's move on and have a look at that. Okay, so first thing you need to know is that Jim's HbA1c has never ever been to his set target, and that is not uncommon in people with type 2 diabetes. At diagnosis, it was 81, which is high, and he was started on metformin. He now takes 1 tablet twice a day, 1 gram twice a day. He admits he's got a bit of a sweet tooth, and haven't we all? And he also admits to forgetting to take his medication at times. His HbA1c at his last review was 70. Now, because of that, they added in a second anti-diabetes medication. So Jim is now on 2 separate anti-diabetes drugs. And his HbA1c today is 68. So his last review was 6 months ago. So it has only come down a couple of millimoles. And we maybe need to have a think as to, you know, why is that? So I want to show you now a really good way of kind of for you to make sense of an HbA1c, but to also put it in context for your patient. So that's Jim's target. We've set it at that, and I think we set it at that with a good rationale. We know that his current HbA1c is 68, which means we have a deficit. So Jim is 15 millimoles off his target. What we've got to kind of work out now is how do we get rid of those 15 millimoles? All the drugs that we use, do you know they've only got a limit as to how many millimoles they can take off an HbA1c? And it is unlikely that the other drugs that we've got on offer will take 15 millimoles off. And this is where that diet and exercise comes in. You know, the thing about diabetes is the drugs can only do so much. But from our perspective, from you doing this follow-up review, what we need to kind of have a look at is really what happens next. And so we're going back to our trusted old to-do list. So the first thing that we need to put onto our to-do list, and this will be to discuss with a clinician, is that his HbA1c is still not to target, despite him being on 2 classes of drug. So this is something that you will need to discuss with the clinician. So that's your first item on your to-do list. Okay, next let's move on to the other aspect, and we're now looking at his blood pressure. Again, I know that you've read all of this on the PDF in the last lesson, so you know exactly where we're up to with this. So let's have a look at our lovely Jim. So we know that Jim is under 80, so we know really what the target is. At this moment in time, we've not got any information as to whether or not he's got CKD. So we'll need to double check that before we kind of decide, is his blood pressure all right? So we'll go back to that in a short while. So let me show you what his blood pressure is today. Jim's blood pressure is 134/84. If he's not got CKD, we're actually quite happy with that. If he has, well then we're not so happy. So we do need to kind of cross-reference this. His pulse is 90, which is a little bit fast, but the good news is it's regular. So we can kind of not get too stressed about him having something like AF. Jim is prescribed an ACE inhibitor for his high blood pressure, which is fabulous, which is what he should be prescribed if you look at, the guidelines. He does not forget to take his medication because he knows that high blood pressure can cause strokes, right? He knows that. His dad had a stroke and Jim does not want to suffer the same. I always find it very interesting, me in a diabetic clinic, when a lot of the patients know about the perils of things like blood pressure and cholesterol, but often they've not kind of started to form a link with too much sugar and damaging blood vessels. I once did a project a few years ago, and it was a diabetes project, and I was given, I think it was about 50 patients who were poorly controlled. My job was to look for factors as to why they weren't properly controlled. And of all those 50 patients, I asked them, did they have any idea as to what too much sugar does to blood vessels? And not one of them had a single clue that sugar was toxic to blood vessels. The other interesting bit was not one of them could tell me what had changed inside the body, what any of the defects were. And as a consequence, they had absolutely no idea how the drugs were working. Patient education in diabetes is absolutely paramount. It really is. So, moving on. From our perspective, a blood pressure of that is below the target set by NICE, as long as Jim does not have CKD. And so therefore, we do need to double check where he is up to with his EGFR and his ACR. So his last EGFR was greater than 60, but there's absolutely no record of a recent ACR. And the one he had at diagnosis came back as being 4.6. So 4.6 is too high. As we discovered when we did the CKD module, we need it to be less than 3. But the other thing that we discovered in the CKD module, if you remember, is that certain factors can influence that. And Jim actually said he forgets to do an early morning sample, and he confesses that the one that he gave at diagnosis was actually done after he had arrived at the surgery. And we do need to know that Jim walks to the surgery and it's 3 miles away. He does it to get his 10,000 steps in. Nevertheless, how much could have all of that exercise have impacted upon the accuracy of that test result? If you remember how we get the test result, ACR creatinine ratio, and if you remember what creatinine is, it's a byproduct of muscle metabolism. So if you've got a patient that's just walked 3 miles, has his muscles generated more creatinine, and as that, what's responsible for this? So to be honest, at this point, we don't even know whether or not we can take any notice of that. Okay, so just hold that thought. Because we're going to put that on our to-do list. No recent ACR, and we've now cast in doubt on the quality of the one that was presented at diagnosis. Then looking at the lipids, again, I know that you've seen all of this, so I'm not going to bore you to death with it. What we need to check is is Jim on the right dose, and also are we seeing a reduction in his cholesterol results. Okay, so at diagnosis, Jim's ratio was 6.2. We know that that is really, really high. And we're thrilled to see that he was prescribed atorvastatin 80 because of his established atherosclerotic disease, his angina. And he tells you, again, just like his blood pressure, he never ever forgets to take that statin because he does know that cholesterol clogs up arteries. And as a consequence, we've got a really good positive test result because it's now dropped down to 4, and we're quite happy with that. So there are the pennies, if you like. There's a couple of bits we need to kind of think about, but I just want to move on to additional care process information because there's some bits in here that we haven't covered. We need to look at what is his height and weight and BMI. And Jim has put 2 kilograms on since his last review. Now, he does blame this on a cruise that he and Anne went on because it's just recently been their 50th wedding anniversary. But his BMI is now 28. Jim stopped smoking over 20 years ago, but the thing about this is even though he stopped 20 years ago, up to that point, he had a 20-year pack history. So that means that all the things that you can get for smoking too many cigarettes, they still are there with Jim. So we need to be careful that we don't forget that. But the positive is he's not smoking now. And his foot assessment. Well, we noticed that Jim has got callus formation on both of his feet. No signs or symptoms of neuropathy or peripheral vascular disease. So we're very happy about that. And he has had retinal screening. Unfortunately, he has got background retinopathy in both of his eyes. Jim is up to date with his retinal screening. Okay, so when we look at all of that, we've got to go back out to our to-do list. There's a couple of things on our to-do list. The first one being that he has put weight on, so we need to kind of have a think about how we're going to deal with that. And also, he has got callus formation. And believe it or not, callus formation on its own increases his foot risk. I have made a PDF and it will follow on after this video, and it is all to do with the diabetic foot assessment. So it would be really good if you kind of could go through that, because that then would expand upon exactly why is a bit of hard skin classed as a risk for foot ulcer. So as we kind of get towards the end of our follow-up review, again, like all of the other modules that we've been doing, in the first instance, we have to report any findings that you have identified as being an actual problem. And I've generated a list of these. I think the first one is HbA1c is still not to target. He's not got any recent ACR, and as a consequence, we can't assess his kidney function. We don't know whether or not Jim's got CKD or not, but we need to know, because if he has, then we'll be adding high blood pressure to this list. So we need to sort that out. And he's also got his weight gain and his callus formation. So that are all the actual problems that we have identified as a consequence of this review. And I know you've seen this before in all of the other videos that we've been going through, your to-do list may very well grow following on from a discussion with the clinician, and it might be that, you know, the clinician says, right, I need you to sort out an ACR. Where are we up to with Jim's patient education and all of this business? Which kind of leads me on to this bit. It's absolutely paramount, and I know I've mentioned this in previous videos, but Jim will probably spend a maximum of 2 hours a year with you. The rest of the year he's on his own, trying to manage his diabetes and look after his wife. So we have to support in education the best that we can. And one of the things I want to just say to you before we finish is, when you do one of these annual reviews, you end up doing several annual chronic reviews in one, because of the way that hyperglycemia damages blood vessels, because of its impact on absolutely everything. An annual diabetic review or a follow-up review, it's more than just one disease review. And it is not uncommon for people with diabetes to have multiple different opathies going on in there. And just to kind of finish off on one thing, is when a person gets a diagnosis of diabetes, their life literally changes forever. Their life is never ever the same again. And so what we can't ignore is the high risk of things like anxiety and depression and stress. And all of these things in turn can impact on outcomes in diabetes. So I hope you found this useful. Do go through the diabetic foot assessment as well, because that does form part of your role within diabetes. And hopefully I shall see you in the next module. We're actually moving on to look at the respiratory system. So we're going to be looking at asthma and then COPD. So take care, and I shall see you in the next module.